Here we go. So it's great seeing you again.
Thank you for having me.
Why don't you tell our audience just a little bit about you, who you are, what you do, and a little bit about your company?
Sure. So my name's Ashish Mandavia. I'm CEO, co-founder of Sohar Health. Sohar Health essentially automates front-end revenue cycle management for providers around the US. We currently help providers to answer the really basic, but actually quite hard questions. So does this individual have insurance in the first place? If they do, are they eligible for the care they're about to receive? What would be their benefits? Are they in network? And lastly, if they are all of those things, what would be an in-network cost estimate for that individual patient? And typically this would take a front desk admin staff member somewhere in the region of 20 minutes to 2 hours to 2 days to figure out.
Yeah.
And we cut that down to 20 seconds for your API.
That's amazing.
And so now we handle over 20 million of these transactions on an annual basis. And we've learned a hell of a lot about how to improve conversion in the intake flow, particularly in the outpatient ambulatory setting, but there are applications throughout the healthcare system. In order to prevent kind of denials happening later down the line after the fact. And as we all know, a lot of claim denials are associated with not doing the work up front.
Right.
And so anything that you can do to mitigate that and do it at scale will help a provider organization to increase their claim collection rate, reduce their claim denial rate. But I think what's really cool about this is actually increase their top line revenue, like get more appointments booked, more scheduled in, get patients being seen faster.
Right. He's speaking our language, right, Zach?
Yeah, reduce that cost to collect.
Yeah, that's right. Yeah. So we met was it at Health last year or ViVE or where?
So we met at Health 2 years ago.
2 years
and then
ago,
Health
that's
again
right.
Last year.
That's right.
So I've been following the Jorie story. It sounds like you guys are doing an amazing job.
Yeah.
I love the fact that you're utilizing AI significantly in so many different parts of the RCM tech stack. And I think it brings up a very interesting question as to how much of RCM should be done via AI agents, via RPA, versus leveraging kind of API-first solutions. So probably leveraging a bit more around kind of ML and LLM. So I would be happy to talk about it.
Well, congratulations on what you've done, because we've been following you as well, and I know you are doing amazing. So congratulations for that. Zach, why don't you talk a little bit about, we were talking about, Ash and I were before we started, about API and the utilization of that versus RPA. And so talk a little bit about what we're doing and, how we've actually talked to Ash about partnering together.
Yeah, well, I guess I'll start with, let me move this a little closer. The model we kind of operate, we'll use whatever technology necessary to get the data that we need. And you guys probably run into this to an extent, but not all payers, as you go through the RCM lifecycle, have APIs or standard integrations, system integrations that you can leverage to get data. So we employ different types of mechanisms to gather that data, but our main goal is to get it back into the provider system or the administrator systems so that they can leverage it rather than having to log into a new platform and learn a new system, new rules and whatnot. We want to make it very prescriptive. And kind of where you were going with this was, well, how much AI or automation should be leveraged in RCM? And I think that's a nuanced and dynamic question depending on the facility and their makeup of payers and what they do. But I think the goal over time would be it's 100% automated to some 100% automated. The biggest challenge with that is the payers complying with the means you can exchange data. And I think we've gotten very good at working around the hurdles that they throw up, but would love to hear kind of your opinion or thought process on that.
Yeah, I think certainly I've got some opinions on it. So,
I bet we can stay here all day talking about that.
Especially about like aligning of incentives there. I think you're totally right. And ultimately, I think it's no wonder that we've seen a huge amount of investment being poured into the utilization of AI in RCM, because I think it's the first kind of real space where investors can see the utilization of AI in its full force in the healthcare space. And yes, there are lots of other kind of areas in which it can be useful, particularly around kind of ambient scribes and stuff like that. But ultimately, the direction that they're going is how do we leverage that to then get into middle RCM, right?
Sure.
Where they can look to monetize it. I think ultimately it's a combination of both. For our customers, if we were to simply leverage only RPA style agents, the challenge with doing that is that you would compromise on speed.
You would.
So
I've heard that from Zach a time or two.
Right, exactly. So where agents can do checks that we perform in perhaps 2 minutes, we can do it in about 3 seconds.
Yeah.
So in fast-moving, high-volume settings, like in outpatient or in telehealth, it really does make sense to leverage API.
Sure.
Now, the challenge with API is that it's hard to integrate. You require engineers, product folks in-house to be able to leverage that. So that's why I always say it's a bit of a combination of both. If you do have that ability to integrate an API with Sohar, then yeah, great. Apply it in the places where it makes most sense to do things at speed, where you need a high degree of accuracy. If you can't do that leveraging of Sohar's APIs, then you've got to work with what you have within your EHR or your CRM.
Yeah.
And that's where we have to put a lot of effort into kind of ensuring that those integrations are already pre-built, or work alongside our customers to do those integrations for them, or work alongside folks like such as yourself who already have those deep integrations within providers' existing systems and tech stack. So yeah, ultimately, I think it's a combination of all of it. In terms of that point around validity of data, the compliance that payers have with providing that information, I think it's changing over time. It has to. I mean, there's a lot of CMS, top-down policy and regulatory stuff. There are always the faster movers and there are the laggards, but I think ultimately, when we kind of take out of the equation the slightly affected dynamic of payers, providers, where one side is looking to kind of get paid the most that they can, and the other side is not looking not to pay out as much as they can.
Right.
Once we kind of see that through, I think ultimately everyone is aligned that they want to be able to deliver the best possible care, efficient care, improve access to care, and if that means improving data validity and the level of data that's passed through, I think payers are all for it. And I've seen plenty of examples even here at the conference of where payers are actively trying to invest in their data in order to improve the exchange of data transfer. And what I like about in our case is that we're willing to kind of partner with anyone who's got good sources of data to be able to pull on them to be able to bring about the ultimate goal of improving access.
So I've got a couple of things, Ash. So Zach, we were talking earlier about how the whole, some of the BPO organizations have gleaned onto the RPA. While they're saying they're automating, they've just got armies of people behind the scenes. Talk a little bit about kind of where we've seen that, because we've seen that in fact happening.
Yeah, I would say I see it maybe less about the RPA side, Chris, but that is a factor. But I think it's more of a black box where they've gotten really good at you thinking it is automated, and this typically happens with prior auth, coding, and to some extent denials. But denials, they have their reasons for it. But the prior auth and coding, what you will see is they will interact with you at an HL7 or API level. Right. And behind the scenes, they have thousands upon tens of thousands of people pushing through that volume to do so. So on the front end, it looks old technology, but on the back end, whether it's through looking at their books or maybe once you send them a large amount of files that they can't get back to you within hours or seconds, like you were mentioning with APIs or even RPA, that should be very achievable. But when you have people, it becomes very obvious it's not when you try and push scale and volume. If that makes sense.
I think the key thing to hone on, the key metric to hone in on is accuracy. One of the key things that we find, because we can't automate every check. So in about 98% of cases, we can automate it via API. For that delta of 2%, we have to rely on BPOs in order to pick up the phone or go onto a portal to be able to pull that information. And by QAing their work and comparing it to actual ERA data, which is what we do across the board of all the checks that we run, you see a significant drop-off in accuracy and quality of the check that's being run. Classic scenarios would be when looking up a copay, co-insurance benefits check, they will switch the copay and co-insurance round when they return the data. And it's like, there are very few checks and balances on organizations like this as to whether they're doing the work correctly in the first place.
Sure.
And I think what I find very interesting is that in countries where BPOs tend to exist, like India, they have, globally now, they have a wave of new talent on the market because so many jobs are now getting lost.
Right.
And so now you get more and more kind of inexperienced people coming to the table.
Yeah.
And that level of ability to train, develop that talent is really important to ensure accuracy and validity of the data coming back. And secondly, they're just getting squeezed so much on their models. So now they're getting forced by the market to move away from the typical model of contingency basis. We take a % of the claim that's been recuperated, but to more like transactional base. And if they're doing transaction based and relying on humans, that becomes very costly and their margins are razor thin. So I think it's a fascinating space. I can totally see how, as some of these organizations get bigger and bigger and they have huge investor bases, some of them are publicly listed companies, they're going to have to invest in technology and leverage that. It's whether or not they're using that technology to empower their existing workforce just for the purpose of reducing operating costs, or whether they actually believe they can be technology solutions, like what we are, which is tech first.
Right.
You brought up an interesting point on the QA drops down when you have to outsource to BPOs, specifically when you're calling insurances.
Right.
Do you think that's because they're misinterpreting the data they're getting, or they're getting the wrong information?
Let's put it this way. You go out to Bangalore or Chennai or something like that, and you can sit in a call center where one of the agents is picking up the phone saying, I'm calling on behalf of provider X for Joe Bloggs' eligibility information. They're calling up Aetna, right? And they're staying on the phone for about 20 minutes before someone picks up the phone and says, I am so-and-so from Aetna. And that is taking place in the same room, right? Different sides of the room, but same room.
Yep.
And that exchange of information between those two individuals itself is fraught with error and mistake. Being able to explain complex procedures and services that are being delivered and having the other person interpret that correctly and then return back the correct information is really difficult. And I therefore think that there is a cap on how accurate that can be. And I think that cap is around 70 to 75%. So it also brings up the question of, okay, a lot of money is being invested in voice AI tooling for the purpose of calling up the payers. Well, if you call up the payer and they're using, they've got a human on the other side, there's no guarantee that the information that you retrieve from that call that you've probably spent, somewhere in the region of $15 to $30 to actually get, because that's the rate for these voice AI calls, is actually going to be anywhere as accurate. So they may be able to call more frequently because they're able to like send out multiple calls simultaneously, but is the quality of the data coming back as good? And this comes back to a lot of things like, are we training RPA agents on the right sort of data to be able to pick out responses? I mean, particularly in our space, eligibility responses in an accurate manner. Are they able to do that versus what we're able to do using like huge sums of data and using machine learning? And still, it's a combination of both, but I think it will swing more and more towards leveraging of ML, LLMs, as LLMs get faster and more accurate and hallucinate less to be able to pull this data.
Well, our companies are alike, and we're leading with tech, right? We just up front, we're doing that. And I think the companies, the BPOs that we're talking about, they're not doing that. They're trying to secondarily use automation or technology, and to your point, it's just not working. But Ash, right when we met the very first time, you were very open to working with us and, to your point, partnering. Why was that important to you early on when you started your company and kind of broadening your partnerships?
Yeah, it's a good question. I mean, Sohar ultimately is a point solution, and though we focus on an area and quite a comprehensive area of RCM, front-end RCM tends to be quite detached from middle and back-end RCM, which are much more intimately connected. So I think working with partners like Jorie is incredibly important to be able to get a visualization of everything else happening in the RCM tech stack and in the RCM lifecycle. Because all of these things are interconnected. As I go back to the point that I made earlier, if you don't do the things correctly up front, everything up until the point of prior authorization, then you're still going to get hit with a claim denial later down the line, no matter how well you code up that encounter.
Sure.
So that's still, I think, where the dependency lies in this space. And ultimately, I mean, the patient is now demanding this sort of consumer-like experience when they come in for care.
True.
I mean, how is it the case that you can go onto Amazon, put a ton of things into your cart, and know exactly how much you're going to pay for those things before they arrive to your house? Whereas in healthcare, you can think that you're going to pay $50 for the care that you're about to receive, and it ends up being $300. I mean, you know, I always allude to this example because I'm a naive European who has grown up in a system where I didn't even have to think about that. And no doubt preaching to the choir here that Americans are just generally really unhappy with that being the way forward. So given that, you know, front-end RCM becomes a conversion tool, it becomes a product that not only can RCM teams use, but also marketing teams and generally finance teams across provider organizations. And I think that's where, you know, we bridge that gap with working with partners such as yourself to be able to bring that story to the providers, because every provider also wants to deliver the best-in-class experience for their patient. And RCM is integral to that. I'm sure if you were to ask folks, what is the biggest source of complaints related to care delivery to patients? It isn't just what the doctor did or the physician did during the consultation. It was, I didn't know that I was going to have to pay for that. And I think that that's an incredibly important part of the story.
Yeah, we had one of our long-term clients that we've been working with over the last few weeks, and cost and the fact that they were having to get more involved in the day-to-day operations, really because there's some things being dropped on the RCM side. So you don't think of your physician providers having to dig down in it, but that's what's happening. And today, you know, they've got to roll up their sleeves and do it because it's so important.
Yeah, I think it's one of those interesting dynamics of the US healthcare system that the provider themselves are so heavily entwined with the costs associated with care delivery. And so, anything that can be done to kind of mitigate that, to be able to handle the patient experience. I mean, as simple as explaining what a copay, co-insurance deductible actually means. I think I read an interesting stat that only like 4% of people in the US actually know how to read their kind of eligibility information. And this is why so much of that onus and responsibility is on the provider to be able to educate them about that and be able to tell them about that upfront prior to actually taking them forward as a patient.
So I have a question that, as you were talking about accuracy and QA, I sort of thought about and similar to us, you know, our data that we return is only as good as the data we get to an extent. How do you mitigate that when, or if at all, when you get, you know, poor data to you that results in inactive or incorrect data downstream that you're submitting?
Yeah, so it's that classic example of bad data in results in bad data out, right? So in our space, particularly one of the big challenges that we have is that when a patient comes to fill in their intake form, their registration form, or a referral comes in, it will come in with incorrect spelling of the patient's name or an incorrect date of birth. Or it's amazing how many patients in the US have a member ID on their insurance card that reads IDK, as in I don't know. I don't think that that's the common practice for generating member IDs. So the way we mitigate that is that we try and take as much off the patient's plate as possible. So we don't do things like OCR. We don't do things like asking the patient individual for that information unless we absolutely have to. Instead, we rely on insurance discovery. And we've built our own proprietary insurance discovery tool that has a very, very high hit rate in terms of finding an individual's insurance. And if we find that individual's insurance, we know that insurance is active. And if it's active, then we can take them through the rest of the process. In terms of incomplete data thereafter, it's all about increasing the number of data sources that you have, because where one clearinghouse or one set of data may fail, you need to have those contingencies in place to go to other sources to be able to find that information. It's amazing how many different data sources that exist that can tell you the same sort of thing or give you an idea about the same picture. And that's something that I think we have just found that we pull on those strings or those threads that maybe others don't. maybe because we're naive and European about it and just think, well, why
Right.
isn't that data
Right.
here?
Right,
Where
right.
else? Who else has this data? And that is we've kind of used as a bit of a superpower. But then the final element to that is like, how do we actually determine where we were accurate or not with our checks? And we use claims data as the kind of source of truth there.
Yeah.
Now, as you guys know, claims data itself is not always accurate, right?
It is not.
And so what we're seeing is that there are ceilings that we come to with certain payers where it is always the case that the payer adjudicates this claim incorrectly because they just haven't even realized themselves that there is a different deductible applied when it's telehealth versus non-telehealth consultations, right? And we hope that the data and the insights that we generate from the data that we have then enables and equips the provider to be able to go back to their